Hi, good morning, everybody. We'll talk today about management of abnormal pap smear. We spoke about the screening and the advantages and disadvantages and different modalities in screening for cervical cancer. So, as we said last time, the cervix contains ectocervix and endocervix. So, when you have an ectocervical lesion, you expect an epithelial squamous abnormalities. If you have an endocervical lesion, you expect a columnar or glandular abnormalities, and this is very critical. Once you have a laboratory or cytology report from somebody in any hospital, whether you are in Jeddah or Makkah or wherever you are, you should expect one of the findings and shouldn't deviate from the standards of reporting system, because the management will depend upon the guidelines and it depends upon the type of abnormalities. We can see here it's an epithelial squamous abnormalities, meaning ectocervix or vagina, or could be also the vulva. So what you expect is to see ascus or asc-H, as well as L cell, high cell, or squamous cell carcinoma. It shouldn't be any other reporting system. And as I said before, once you see it, I always advise everybody, even myself, when I read the report, if you see ascus, read it again to make sure it is not asc-H. As long as we know, there is a major differences between ascus and asc-H, prognosis wise, investigations wise, as well as the outcomes in general. So let's start with ascus, atypical squamous cells of undetermined significance. What does ascus means? Just to make sure that everybody knows what does it means. It means the cytologist will look at the pap smear and he cannot put the patient as a low grade. On the other hand, he cannot report it as normal. So that's why they call it undetermined significance. We don't know what is the extreme outcome of this ascus. So it's not dysplasia and not normal. At the same time, there is a maximum reported tolerance for each lab. It should be less than 5% of all the pap smears done. Meaning if your hospital are reporting more than 5%, you should question your cytologist. Okay, so the maximum reported annual pap smears with ascus shouldn't exceed 5%. So ascus is the only pap smear reporting diagnosis where you don't need to refer the patient for immediate colposcopy, because there is a differential diagnosis for ascus. The differential diagnosis could be hypoestrogenemia or dryness. That's why we see it in breastfeeding patient. We see it in a patient in the perimenopausal age, or it could be the other differential, chronic inflammation, infection, or HPV related. What we are worried about if it's HPV related. So the management of a patient with abnormal pap smear with ascus is the following. So because it's very common to see ascus, we need to make sure what should we do with the patient. The options are to repeat the pap smear in 4 to 6 months. The second option is to give the patient local estrogen like Primarine for 3 to 4 weeks, and then should be off treatment, and then repeat the pap smear after 3 months. Or you do what we call it reflex testing. This is here. You remember we spoke about pap smear, we call it co-testing when you do it at the same time. But here we have what we call it reflex testing, meaning you did have a patient with abnormal pap smear, ascus, and now as a reflex you are checking the serotyping to check if the patient is HPV negative or positive. To repeat the difference between co-testing and reflex testing. Co-testing, it was one of the screening options where you do pap smear as well as serotyping. This is called co-testing. But reflex testing, meaning you do a pap smear and then the pap smear gives you ascus, and as a reflex for that you do HPV serotyping. If the HPV serotyping is positive, you refer the patient for immediate colposcopy. If the serotyping is negative, you just continue on doing annual checkups for the patient because she is negative. If you did the pap smear with ascus after 4 to 6 months, if you refer for annual checkups. So the indication to refer a patient with ascus for colposcopic assessment is positive HPV or repeat positive pap smear. If it's positive, you refer the patient back for colposcopy. If you did it after the cream or the local estrogen and it's positive, you refer for colposcopy. If it's negative. Other classes of the squamous abnormalities, which is low grade, high grade, atypical squamous cells cannot rule out or exclude high grade, as well as squamous cell carcinoma. All the other classes should be referred for immediate colposcopic assessment. So just to make it easy, if you have a squamous abnormality and then after that you repeat it in 4 to 6 months. This is one option for ASCAS, while the other abnormal pap smears, you refer the patient for colposcopy. With ASCAS, you do repeat it in 4 to 6 months, or you do HPV serotyping, or you give the patient local primarin. The remaining abnormalities as glandular, which is endocervix, we know that it's columnar epithelium. And usually in columnar epithelium, we have a differential. It could be endocervix or it could be endometrial or endocervical tissues. So we don't know which and which. And that's why any abnormalities as glandular should be reported as atypical glandular cells, AGC. There is no more AGAS. So please, if you have a patient comes to you with a cytology report as AGAS, as we said before, call your cytologist and tell him AGAS is not there anymore, because he should tell us atypical glandular cells NOS or atypical glandular cells favor endocervix or endometrium, or atypical glandular cells as adenocarcinoma. The management of abnormal pap smear with atypical glandular cells, which is atypical glandular cells meaning AGC, you should refer all the patient for immediate colposcopic assessment. Again, there is nothing called AGAS. It has to be atypical glandular cells, and you should know what is the subclass of atypical glandular cells, meaning NOS or favor endocervix, favor endometrium, or its favor neoplasia, because that will determine the next step of management. But in general, refer all the patient with abnormal glandular cells for colposcopic assessment. About cytology and histopathology, we know that cytology will give you low grade, high grade, or will give you ASCAS or ASC-H. On the other hand, when you talk about CIN 1 and 2 and 3, it means this is histopathology, which is more reliable, more sensitive, and that's why you refer the patient from a screening test like cytology, pap smear, to a confirmatory test, which is colposcopy, and to take a colposcopic biopsies to have the reporting pathologic report as CIN 1 or 2 or 3 or cancer. As you notice here in the last column, CIN3 is equal to carcinoma in situ. In the past, we used to say there is a grade between CIN3 and carcinoma in situ, but not anymore. When you talk about it, it's all the same. It's a severe dysplasia. We call it severe dysplasia if it's a CIN3 or carcinoma in situ. We call it mild when it's CIN1 or moderate when it's a CIN2. See quick normal pap smears, and as we said before, when you look at normal pap smear, if you can see the arrow, we usually look at the nucleus, and nuclear changes replaces what we call it or explains the dysplasia. The term dysplasia is nuclear changes where you have hyperchromatism or altered nucleocytoplasmic ratio. This is called acidophile and basophile. Acidophile meaning it's toward the pinkish or reddish. Basophile is toward the bluish, and the cytologist can tell which day of the cycle roughly the patient is from the pap smear you can see. And as we said before, dysplasia meaning hyperchromatism, increased nucleocytoplasmic ratio, as well as presence of micronucleoli and increased mitotic activity, which we're going to see in the other slide. See in the nucleus there are nuclear changes where you can see an increased in size nuclear changes, as well as if you look there is increased hyperchromatism. If you want to see more clear, you can see it in the net. Actually, you can just put abnormal pap smear, and this one is also abnormal. You can see there is a micronucleoli inside, increased nuclear size compared to the cytoplasm, as well as from here you can tell this is a high grade. As you can see here, there is a micronucleoli inside. So this is all typically abnormal pap smears. This is, you can see, maybe carcinoma. Honestly, I'm not the best or not expert, but you can see there is increased. You can see in this slide in particular there is increased like mitosis, as if the cells is going to be divided, and there is some other normal cells in the other periphery, but in general this is a typical abnormal pap smear query carcinoma. Talking about histopathology, so this is more reliable. Talking about CIN 1, 2, and 3 or carcinoma, this is the basement membrane, as you can see the marker. And then as we know that HPV usually goes all the way from the surface epithelium going to the basement membrane, and then it will start the oncogenic changes on in the surface. What we know that when we say CIN 1, 2, 3, you divide the area into 3 thirds. So this is CIN 1 affected the lower third or the inner third, CIN 2, and then CIN 3 meaning all the thickness or full thickness abnormalities or oncogenic impact of HPV. See here, this is a basement membrane, and this is like a cervical dysplasia where you have the nuclear changes in the lower third, probably the lower 2 thirds, and this is maybe CIN1. And as I said before, even in the exam, they won't give you something very complicated. Usually it's either CIN1 or CIN3. This is another slide where you have a full thickness abnormalities. As you can see here, this is basement membrane, and the entire thickness of the epithelium is affected with abnormalities. As you can see, the nuclear changes applicable to all the layers. So this is severe dysplasia or CIN3, and this is again full thickness dysplasia where you have the basement membrane here going from down CIN1 to 3. So the entire thickness is affected. About what we explained before regarding the ectocervix and endocervix, this is what we're talking about. Endocervical glands, which is columnar, which is adenocarcinoma, or ectocervix, which is squamous or squamous cell carcinoma, which goes with vagina, which goes with vulva. So endocervix goes with endocervix or endometrium, and that's why different inspections and modalities we're going to do for colposcopic assessment, it depends upon what type of abnormalities you got in your pap smear. So before you refer the patient to colposcopic assessment and before you do the colposcopy, you should know what type of abnormality you received by the cytologist. This is colposcopy. Colposcopy simply is an amplification of the cervix, vagina, and vulva. It depends upon what abnormality you have by the pap smear. Usually you make sure that you explain to the patient, you take consent, make sure that you have a proper lighting, you make sure that always adjust the knob at 10 times 10. When you put it 10, it means the cervix is amplified 10 times. So here this is our amplifications, and this is what we look at. We look simply at what we call as aceto white. This is the term aceto white area. Everybody should know what is aceto white, and everybody should know what are the different modalities we use in colposcopic assessment to assess the cervix and where to take the biopsy, because the idea of doing colposcopy, you are converting the what you call it cytology into histopathology. So you apply certain dyes to find out where is the abnormal area to take the biopsy. Out the abnormal area, you take a biopsy to convert the cytology into histopathology, which is more sensitive and reliable, and then you can tell this is CIN1 or 2 or 3, and then you can manage the patient accordingly. So here we use the acetic acid. We know that acetic acid will cause dehydration of the dysplastic cells. So cervical cells with dysplasia will turn into white, and this is where you can tell where is the aceto white area, and this is where you take the biopsy, and we call it aceto white. And you have different densities, could be faint, could be dense. The more the dense, the higher the dysplasia. And then we have Logell's iodine. Logell's, the idea of Logell's iodine, it depends upon the glycogen content of the normal cells. So the idea of Logell's, we know that the normal cells contains or rich in glycogen. The abnormal areas are deficient in glycogen. So once you apply the Logell's iodine, the normal area or the normal cells will uptake the Logell's. However, the abnormal cells will not take the Logell's because it's deficient on glycogen, and that will give you what we call it mustard yellow. Mustard yellow is the defective or the abnormal dysplastic cells. Here, this is typically what I just explained. If you look in this area, this is an area where it did not take the locals, and this is this plastic area. This is called mustard yellow because it's deficient on glycogen. However, all the remaining normal cervix is full of glycogen, so it will take the locals iodine. This is also another dysplastic area, and this is another dysplastic area, which gives you a mustard yellow. Another example where you can tell this is deficient in glycogen, so this is dysplastic. So this is the area where you need to take the biopsy from. And the remainings are normal area where it takes normally the locals iodine. We use also Monsell solution. This is ferric subsulfate. Usually you use it for hemostasis after taking the biopsy, or if you have a patient with severe bleeding from cervical dysplasia or cervical cancer, you use Monsell solution for hemostasis. We use also silver nitrate stick, and this is also for hemostasis after taking the biopsy. Filter, why do we use green filter? Basically, we use green filter to identify or exaggerate the abnormal vessels. We know that cancer or dysplasia creates a new vascularization because of the high oxygenation or high oxygen requirement. So as you can see here, this is an area where you have an abnormal vessels. This is what we call it mosaic form, or what we call it punctation. So this is punctation and this is mosaic form, and the idea of using the green filter to exaggerate it. So this is without a green filter and this is with a green filter, and again it tells you where to take the biopsy from. Now you did your colposcopy, you used the acetic acid, green filter, local iodine, you did identify where is the abnormal area. This is where you're going to use the biopsy gun or punch biopsy to take the biopsy from an abnormal area to determine what degree of dysplasia you have. Sometimes if you have an endocervical lesion, you need to go with ECC, endocervical curettage or endocervical curette, and this is to sample the endometrium. As you can see here, you are taking cells from the endocervix to determine where is the abnormalities. However, if you have a patient with abnormal glandular cells and you refer the patient for colposcopy, you need to do endometrial biopsy. Here, as you can see, it depends upon what abnormalities you got by pap smear. If you have a patient who came with abnormal squamous cells, you need to do, abnormal glandular cells, you need to do colposcopy to assess the ectocervix. You need to do an endometrial biopsy and ECC because this is glandular. While if you have a squamous cells, you need to do colposcopy to determine the abnormal area, and then you take an ectocervical biopsy for squamous abnormalities. Few words before we end this presentation, because there is always a mix-up about what is the transformation zone. We know that during childhood there is what we call it the original squamocolumnar junction, and after puberty, because of the acidity, the squamocolumnar junction, with a junction between squamous and columnar, will regress and disappears. This is the new squamocolumnar junction. So the transformation zone is the distance between the new and the old squamocolumnar junction, or the new and the original squamocolumnar junction, and this is the most likely area to have cancers in the future, and this is where the dysplasia starts usually, and you have to see it to consider it what you call it satisfactory colposcopy. If you don't see the transformation zone, this is unsatisfactory. If the lesion extends into the endocervix, this is also unsatisfactory colposcopy, and you need to do an ECC. وبالتوفيق للجميع. Thank you.